Second day in Madrid. More than 23,000 attendees joined the Congress today. Lung cancer dominated the scene at the presidential symposium. Other hot topics: genitourinary tumors, supportive care, and public health issues.
I think that for non-negative patients, trastuzumab is absolutely not obsolete.
Maybe in the future you can add many treatment, no problem. For no absolute.
One of today's controversy sessions raised a key question in early breast cancer, as a lot of agents proved to be effective in combination with trastuzumab over the last few years. Selecting which option is the best is still an issue, and limited availability of agents in some countries can drive clinical decisions. Given this, will combination therapy ever replace monotherapy?
I think it will replace a lot of monotherapy, but not for all patients, and it depends on the setting. We have the neoadjuvant setting, which is a short-term dual blockade plus chemotherapy, so we have a good notion of how the tumor responds at the time of surgery, and there may be a lot of patients who don't need the 1 year of dual blockade, and there's patients like small node negatives up to 2 centimeters who do just fine, as we know from the Dana-Farber data, with trastuzumab plus a short period of paclitaxel in the adjuvant setting. So I think dual blockade will be a good option for a lot of patients, in particular the high-risk patients, node positive, ER, PR negative, but it's not going to be for everybody. And we also have the extended treatment with neratinib, which seems to have a particular interaction in the HER2 positive, hormone receptor positive population, probably because of the two pathways, ER and HER2. And I think this is also an exciting option, and we need much more information, much more data, subgroup analysis, in order to tell the patient in front of us next Monday what we're going to offer her.
When cancer occurs, it has a major impact on every aspect of a patient's life. But quality of life is not the only factor that needs to be taken into account when discussing long-term consequences of the disease. At ESMO 2017, 2 trials highlighted the key importance of measuring the economic burden of cancer in terms of productivity and work days lost, both in cancer survivors and cancer patients. The NOR-KAYAK study, involving 1,198 participants with different types of cancers, showed that psychological and physical late effects of cancer can be associated with reduced workability, and that only 60% of survivors had a full-time job after a median of 13 years since cancer treatments. A second study outlined a more dramatic scenario in advanced gastric cancer settings by collecting real-time data through a cross-sectional survey in 6 countries. Results showed that 74% of 724 patients involved were retired, unemployed, or on sick leave, and a loss of productivity was also reported in patients' caregivers, with 76% of them unable to work or working less hours. These outcomes suggest that even if cancer therapies eventually stop, their effects can last indefinitely for patients, and for this, more awareness is needed for survivorship issues. The ESMO Women for Oncology session was held today, offering a unique opportunity to discuss gender disparities in oncology and share opinions on how they can be overcome. Maybe ESMO cannot rapidly change things at national levels in terms of policies, commented Solange Peters, chair of the ESMO Women for Oncology Committee, introducing the session. But I am sure that we can build many initiatives for changing the perception of gender-related issues in oncology today. After lively and productive roundtables, which were joined by ESMO President Fortunato Ciardello and ESMO President-elect Josep Tabernero, Frances Shepherd, Professor of Medicine at the University of Toronto, received the ESMO Women for Oncology Award. She is unanimously considered a true role model for all women working in the field.
Women, you can have anything but not everything. You have to make decisions. You're going to have to work hard and make career choices because it's harder for you as a woman, because you do have more responsibilities at home. You have to focus, you have to be self-disciplined. Look to both men and women. I didn't have any female mentors. There were only the 2 other women in other subspecialties at my hospital when I started. But collaborate with everyone and be a mentor to everyone.